اليوم تكملة محاضرتنا عن ال defense mechanism of the dentin and the pulp against external stimuli. فوصلنا إلى النقطة السادسة اللي هي تتعلق بالpulp inflammation. شرحنا بالمحاضرة السابقة عن ال defense mechanism. The dental pulp is a loose connective tissue containing blood vessels and lymphatic and nerves and undifferentiated connective tissue cells. حال بقية connective tissue اللي موجودة بالبودي. Inflammation is a response to injury or infection. Histologically and physiologically, the inflammation is similar to that occurring in other connective tissue. في حالة inflammation of the pulp يكون similar to the other connective tissue. However, the long-term response of the pulp to severe irritation is different than in another tissue. It is a unique one. Why? لأنه عندنا سببين, because of two reasons. First of all, the pulp is surrounded by a hard tissue structure اللي هو الdentin, وعندنا النقطة الثانية small apical foramen. هذين النقطتين أو ذين الفيتشرز of the pulp راح تسبب لنا بعض المشاكل في حالة inflammation of the pulp. First of all, the pulp has no room in which to swell because it's surrounded with a hard structure. This inability to swell may well lead to increasing cell death in an ever-widening area. بما أنه ما يقدر يصير بيه swelling, فممكن أنه راح يصير pressure inside the pulp واللي may cause increase in the death of the cells in a specific area. Secondly, lacks of collateral blood supply. Extra nutrition and defenses cannot be marshaled quickly to the area. Because of the lack of collateral blood supply, the pulp cannot have the enough blood supply that enable it to respond quickly to an inflammation and to bring the other cells and material and substances that is necessary for the inflammation process, for repair process, because inflammation contain damage and repair process together, concomitant. Therefore, lack of collateral blood supply decrease this ability of the pulp to cope with the inflammation efficiently. Also, inflammation is a protective response. The immune response may destroy normal cells as well as foreign substances. Again, the pulp with its compromised blood supply is unable to cope with this increasingly severe damage. So the inflammation have two-sided. One is a repair side and one is a damaging side to the host tissue itself. So these 3 points make the pulp very sensitive to the inflammation, especially in case of persistent irritation to the pulp, which will lead to a chronic inflammation of the pulp that cannot be coped by the pulp sufficiently. In a progressive order, the status of the pulp in the response to caries are as follows. First of all, we have healthy pulps, and secondly, in case of mild irritation, we will get hyperemia of the pulp. Then we have acute pulpitis that could develop to a chronic partial pulpitis without necrosis, and we have chronic partial pulpitis with necrosis, a chronic total pulpitis with partial necrosis and total necrosis of the pulp, and also we have acute pulpitis superimposed on chronic pulpitis. This classification is based on histological appearance of the pulp. In the clinics, we cannot distinguish these according to signs and symptoms efficiently. It will be difficult to diagnose whether there is a necrosis or no necrosis in the pulp. So in that case, we depend on the signs and symptoms of the case in order to categorize the case as a reversible or irreversible pulpitis. We will discuss these two terms at the end of the lecture to see what's the difference between them and what's the relevance of them to our clinical practice. Now we will talk about these entities of the status of the pulp. First of all, pulpal disease are clinically can be divided into reversible and irreversible pulpitis, as we say, and are based on the ability of the inflamed dental pulp to return to a healthy state or not. So if it was reversible pulpitis, it will be able to return to its normal status. In case of presence of irreversible pulpitis, that means there is an irreversible condition in the pulp that prevents it from returning to its normal status. So in case of healthy pulp, we have a normal pulp tissue, free of a disease or healthy. Pulp tissue may show a wide variation in its histological structure according to its age and function. However, there is no inflammatory cells in the pulp tissue. As you can see here in the picture, we have normal structure of the pulp. We have odontoblast layer, and we have cell-free zone followed by cell-rich zone, and we have the pulp proper. And there is no infiltration of any inflammatory cells in the pulpal tissue. Of course, the age and the condition or the function of the pulp at a specific age make some variations in the histological picture of the pulp according to the age. In case of initial caries which have not penetrated into the dentin, we can observe that teeth have a normal pulp condition with no infiltration of any inflammatory cells inside the pulp, indicating presence of any inflammation in the pulp. The second case or second entity is hyperemia. Hyperemia is a physiologic term meaning an increase in the blood flow through the tissue. In histology, dilated and congested vessels were seen. Pulp could not be inflamed. 41% of the carious teeth did have hyperemia, suggesting that frequently this may be an early sign of inflammation. The removal of the cause of hyperemia should revert the microcirculation to its normal state. So hyperemia, as we discussed, as we say earlier, it is an increase in the blood flow through the tissue. This can happen in case of mild irritation to the pulp, but still there is no inflammation or any signs of inflammation in the pulp, just a widening and dilatation of the vessels, of the blood vessels inside the pulp. Studies have found that 41% of carious teeth did have hyperemia. However, there is no signs of inflammation. The third entity, which is acute pulpitis. This occurs as a sequence to various operative procedures, including mechanical pulp exposure, also following deep scale. Always an acute reaction developed beneath the affected dentinal tubules. So what's the characteristic or histological characteristic of acute reaction of the pulp? First of all, the odontoblast cell may be destroyed or ruptured by the oedema. Also, there is increased eosinophilia of the connective tissue, Also, there is marked dilatation of lymphatics combined by packing of erythrocytes and leukocytes along the vessel wall and within the capillaries. A clinically acute pulpitis may last for 3 days and it is either disappear or resolve into a repair process or it change into a chronic inflammatory reaction depending on the irritant. If the irritant is persist, so the acute pulpitis subsequently will develop into a chronic inflammatory reaction. Well, the clinical manifestation of acute pulpitis is a mild pain during hot and cold application. The pain remains as long as the stimulus remains. The fourth entity is a chronic partial pulpitis, but without necrosis. This developed from deep dentinal caries or pulp exposure or operative procedures or deep periodontal lesion and orthodontic tooth movement. Histologically, the chronic form usually dominated by small lymphocytes, monocytes, macrophages, and plasma cells, which are abundant. As you can see in the picture, cases of chronic partial pulpitis in young people may develop into a pulp polyp, a condition called pulp polyp. In children and young adults, the hyperplastic tissue reaction occurs because the young dental pulp has a rich blood supply and favorable immune response that is more resistant to bacterial infection. As we say in the beginning of the lecture, that the blood supply is a very important factor in determining the ability of the pulp to cope with the inflammation. So in children and young adults, the blood supply is much richer than older patients. Therefore, the response of the pulp will be a favorable immune response with more resistance to bacterial infection. This is known as pulp polyp. As we say in the picture, this is called pulp polyp. Usually we see it in young adults and children. Also known as chronic hyperplastic, and it is uncommon and specific type of inflammatory hyperplasia that is easy to bleed by touch. The pulp polyp is usually an incidental finding that occasionally mimics reactive and neoplastic diseases of the gingiva and adjacent periodontium. We can differentiate between pulp polyp and gingival polyp. It is easy to be differentiated from the gum polyp or gingival polyp by follow the origin of each by using a probe. Treatment of a pulp polyp include the more conservative vital pulpotomy treatment has been successful in selected cases when only the coronal pulp is affected. There is no necrosis in the pulp, or either root canal treatment or extraction of the tooth when there is necrosis in the pulp. However, in clinical situation, it will be difficult to know if there is any necrosis in the pulp from clinical signs and symptoms. However, we depend on a subjective findings of history, examinations, and called test to have a subjective results of whether there is necrosis in the pulp or not. In case of presence of necrosis, we should do root canal treatment. In case of no necrosis, we can do vital pulpotomy treatment, especially it is usually in children and young adults. The fifth entity is chronic partial pulpitis with partial necrosis. Previous entities, there was no necrosis in them, and this entity we observe presence of partial necrosis. However, also the pulpitis also it's partial. That means it's in the coronal part. It developed from the same irritant as above, but with the persistence of such irritant. For example, if we have a carious lesion in the tooth and the patient did not go for the dentist, he or she did not suffer from any signs and symptoms that make him go to the dentist to remove this carious lesion, the carious lesion will get penetrate deeper and deeper until it become a persistent irritant to the pulp, will make the pulp to be inflamed chronically with necrosis of part of the pulp. This causing area of liquefaction or coagulation necrosis. We have two types of necrosis. We have liquefaction necrosis and we have coagulation necrosis. And the inflammatory lesion extended to a deeper pulp tissue into the pulp proper area. These areas of liquefaction necrosis are called pulp abscesses, since they are surrounded by disintegrated polymorphs, collagen fiber, and chronic inflammatory cells. The available treatment for this type of pulpitis is either root canal treatment or tooth extraction, because presence of necrosis in the pulp that prevent the healing to the normal status of the pulp. As you know, necrosis, whether it's liquefaction, coagulation, it will not resolve or repair to the normal stage. The symptoms of this entity, there is a painful symptoms may occur, and the pain is spontaneous and is due to the pressure of the abscess on the nerve surrounding it. Sometimes the pain may last for half an hour and it does not disappear with analgesic. Sometimes may be a spontaneous pain. However, radiograph should be taken when the tooth in such condition. Sometimes we can see some periapical changes and sometimes there is no periapical changes yet. The available treatment for this type of pulpitis is either endodontic root canal treatment or tooth extraction. The sixth entity, which is chronic total pulpitis with partial necrosis. As we can see here, the chronicity of the pulpitis have become in the total pulp, mean the coronal part and the radicular part. Still we have partial necrosis. And the causes, this develop with the extension of inflammation to involve the entire pulp tissue, the coronal and the radicular, due to the persistence of the irritant and the development of liquefaction necrosis within the inflammatory area or a coagulation necrosis. The signs and symptoms of this condition, there is a severe pain, sometimes lasting for many hours, or when the patient sleeps, this will increase the pressure inside the pulp and cause a throbbing pain. Throbbing pain is very important sign in diagnosis of presence of partial necrosis and chronic total pulpitis. The available treatment for this type of pulpitis is either endodontic root canal treatment or tooth extraction. The seventh entity, which is a total necrosis of the pulp, here we see that the necrosis of the pulp is extending from the coronal to the reticular part. Pulp in which the cells of the pulp have died as a result of coagulation or liquefaction necrosis. Histologically, coagulation cells mean it is still recognizable, but the intracellular details have disappeared. Liquefaction necrosis mean the entire outline of cell have disappeared and the area become liquefied. There is a dense zone of morphonuclear leukocyte with cells of chronic inflammation. Treatment of choice in this case is root canal treatment or tooth extraction. As you can see here in the picture, tooth with necrotic pulp usually will appear as a dark tooth compared to the normal teeth. Here, the central incisor seems that it has a necrotic pulp. The eighth entity is acute pulpitis superimposed on chronic pulpitis. In this case, there is a severe pain, especially at night, till the abscess is formed. Then there is slight relief, but not complete relief unless we do a drainage through the tooth, which means excess opening, or surgical incision with antibiotic cover. We should see the patient within few days and then treatment is continued by root canal or extraction. In this case, we have a chronic pulpitis and then followed by exacerbation of the case of acute pulpitis. So in that case, the patient will develop severe pain at night and abscess formation will be developed, and the relief of the case will be accomplished by a drainage with antibiotic cover or surgical incision. Here we can see in case of that the caries reaching the dentin, if we histologically examine the pulp, we will see a mild inflammation signs and symptoms. Here we have a pulp. As you can see, the caries is extending into the dentin. This is the caries, and we can see the pulp is mildly inflamed. Still, this is a reversible condition that can be easily resolved into the normal status by just removing the caries. Here is a magnified picture of the case. You can see some inflammation inside the pulp. In case of deep caries, according to the extent of irritation and the time of the carious lesion and the extent of carious lesion and the condition of the pulp, there may be a reversible inflammation or irreversible inflammation. In this case of deep caries, there is a reversible inflamed pulp. Of course, clinically, this is difficult to be seen because in clinics we don't do histological sectioning and we cannot look at the status of the pulp to determine what we will do in a clinical situation, whether we will do a normal filling or we do a root canal treatment. So in these cases, we depend on the signs and symptoms, history, and diagnostic tools that we have to determine the status of the pulp in these conditions. So in this case, we see a deep caries, and the caries extending very deeply inside the dentin. However, it did not reach the pulp yet. In this case, we see a reversible inflamed pulp infiltrated with some inflammatory cells, but still there is no signs of irreversible inflammation. As we say, irreversible inflammation means that the pulp associated with the presence of some necrosis. In case of deep caries, this is the case, very deep caries close to the pulp or the horn, the pulp horn. There will be, in that case, they found that there is an irreversible inflamed pulp. There is irreversible damage in the pulp. There is some necrotic area inside the pulp, some necrosis in the pulp that prevent the pulp from return to its normal stage in case that we remove the causative agent, which is the carious lesion. If we remove the caries and we apply bioactive materials, there's no guarantee that the pulp will return to its normal stage because of the presence of liquefaction or coagulation necrosis. As you can see here, in this pulp horn, there is a lot of inflammation and there is some necrotic area. In the other pulp horn, we see infiltration of inflammatory cells with the presence of some necrotic areas. So this is an irreversible inflamed pulp. In case of pulp exposure, again, previous condition were in deep caries. In pulp exposure, as you can see here, lower second molar with a distal caries, and also we can see the wisdom tooth with mesial caries. Here, microscopical sectioning of the tooth after extraction. We see the extent of the carious lesion. It's about 2/3 of the dentin thickness. When we measure the dentin thickness from this point to this point, we can measure the depth of the carious lesion on the radiograph. So here you can see the mesial root and the distal root, the distal lesion on the distal part of the tooth, very close to the pulp. But however, in microscopical sectioning, we can see there is a pulp exposure of the carious lesion to the pulp. As you can see here in this area, there is a big liquefaction necrosis surrounding by severe concentration of an inflammatory cell. On the other part, or the pulp horn, we can see a normal pulp tissue, unlike this pulp horn which is exposed by caries. So you can see the infiltration of inflammatory cell around the liquefaction necrosis. Here we can see on the mesial horn there is a normal pulpal tissue. Here we can see the liquefaction necrosis, and here we can see in this area approximately there is a bacterial penetration to the pulp, which means pulpal exposure. So how we can in a clinic diagnose all these conditions? Broadly, these conditions divided into reversible and irreversible conditions. So pulpal disease are broadly divided into reversible and irreversible pulpitis and are based on the ability of the inflamed dental pulp to return to a healthy state or not after the treatment. So in case of reversible pulpitis, the pulp has no permanent or irreversible between brackets damage that prevent it from returning into its normal condition after removal of the irritant. In this case, for example, in caries, the treatment by removing the caries and do a filling. In contrast to the case of irreversible pulpitis, where the pulp is unable to return to normal condition after removal of the irritant because of the presence of permanent damage. However, diagnosis of these conditions depend on subjective and objective findings only, because we cannot see histologically what is there in the pulp. So we depend on a subjective and objective findings. So in teeth with reversible bite experience discomfort when a stimulus such as cold or sweet is applied and goes away within a couple of seconds following the removal of the stimulus. So in that case, we depend on the history of the patient to cold and sweet irritation. Also, we can apply cold application on the suspected tooth to see the response, and we can judge the response of the tooth to cold test. Why we say it is subjective findings? Because one patient may describe the pain differently from another patient. So we should not depend on the history only, but we should perform our diagnostic test to see the level of inflammation or the status of the pulp in the suspected tooth. However, still, this test is a subjective test, not a definitely objective test. Typically, etiology may include exposed dentin, like dentinal sensitivity, caries, or deep restoration. There are no significant radiographic changes in the periapical region of the suspected tooth, and the pain experience is not spontaneous. Spontaneity of the pain is a very important indicator of the presence of necrosis in the pulp. Also, throbbing pain is also an indicative factor in determining the presence in the clinical determination of presence of necrosis in the pulp. Teeth with symptomatic irreversible bitis, because we have a symptomatic irreversible bitis that does not give any pain. In case of symptomatic irreversible bitis, teeth experience sharp pain upon thermal stimulus with a lingering pain, often 30 seconds or longer after stimulus removal. Spontaneity or unprovoked pain and referred pain sometimes. The pain may be accentuated by postural changes such as laying down or bending over, and over-the-counter analgesics are typically ineffective. The common etiologies may include deep caries, extensive restoration, or fractures exposing the pulpal tissues. Teeth with symptomatic irreversible bitis may be difficult to diagnose because the inflammation has not yet reached the periapical tissue, thus resulting in no pain or discomfort to percussion. In such cases, dental history and thermal testing are the primary tools for assessing pulpal status. So in these pictures, we can see the tools that we can use it in the clinic to determine the status of the pulp, whether it's reversible or irreversible or necrotic pulp. So we can use the the empty carpools of anesthesia and fill it with water and put it in the freezer of the refrigerator. And we can use these carpools as a source of cold application on the teeth that need to be examined for their pulpal status. Also, we can use ethyl chloride spray. We spray on a cotton pellet and we apply the cotton pellet on the buccal surface of the tooth, and we can evaluate and see the response of that tooth to the cold application. Or we can use electric pulp testing to see the status of the pulp. The response of the patient from these tools will determine whether this tooth have an irreversible or reversible inflammatory condition in the pulp. If the pain lasting for more than 30 seconds, we can say the pulp of the tooth is irreversibly inflamed. However, if the pain disappears once we remove the stimulus or after a few seconds, that means the pulp of the tooth is in a reversible state that can be treated by removing of the irritant, and there is no need to do a pulpectomy procedure and removal of the pulp to perform a root canal filling. Differentiating reversible from irreversible pulpitis will definitely lead us during the treatment course to determine our option of treatment.